So for now, Boštjan, welcome. And thank you very much again. And the floor is yours.
Thank you very much, Agnieszka. Hopefully we're good receiving everything video and audio. So thank you for a very kind introduction. And yes, today we're going to talk about the procedures under local anesthesia and how to move your practice away from the conventional general anesthesia operating theater and how to make them more accessible for the patient and the surgeon as well. Okay, so hopefully you're all seeing the first screen. And the title of today's presentation is going to be moving your site of service, which means that moving your surgery away from the operating theater, away from the general anesthesia to the local anesthesia, which is something that it's really paramount in those days. So I just want to introduce to my team, to the team that we're working together, because neither rhinology, neither the skull base you cannot do in isolation. You have to have a team to back you up and to work on a patient as much as comprehensive as possible. So let's go to the topic. So the COVID pandemic in 2020 and until now really increased the backlog of the surgical procedures in many departments, in many specialties, as well as in ours. So we need rhinology, and those backlogs really started to pile up. And this is due to the inaccess to the operating theater, to the general anesthesia, because only certain emergency procedures were being performed. And if you look at, so this is starting to build up also in the PubMed, but if you search backlog rhinology during COVID pandemic or something like that, if you type in, you get 186 results, which is basically a little bit less than I expected, because I would assume that this is a much bigger problem than the papers or the number of the papers would suggest. But probably this is people do not want to talk about it because it's not really a nice thing to have a backlog of patients and you don't know how to cope with that. Well, let me say that we are really experts in this because we have backlogs for ages and decades. So right now, half of the world is in our shoes. So the access to the OR is limited, general anesthesia is scarce, and you've got other specialties, which are, let's say, more aggressive than the ENT are competing for the OR. So we met those problems decades ago, and we just might have a solution for you. So this is what our endoscopic rhinological procedures looked in for more than a decade. So I started to count rhinology, which didn't start there, but with my involvement into it in 2008, 2007, when we started the pan-sinus procedures and we moved from local to the general anesthesia. And you see that it was pretty stable until 2014, 16, when we started to increase a number of procedures that we started to do under local anesthesia, with multiplying number of the procedures. And you can see that in 2019 and 2018, the number of the procedures under local anesthesia, endoscopic rhinological procedures under local anesthesia, really were doubled compared to the general anesthesia. So why moving there? Why to do it under local anesthesia? So people say it's much harder to do that procedure, but it's really not. It could be more fun if you start correctly. So why is the first question. So you got shortage of anesthesiologists, then you have to move to the local anesthesia. Either you have competing for general anesthesia time from other specialties. Okay, you have to move somewhere else, out of the OR, into the procedure room, whatever you call it. And you want to do a faster turnover because you can do a simplified setup if you do it under local anesthesia. So this is our just a rough representation what we did in general anesthesia and local anesthesia in the last from 2008 to September 2019. And you can see what we did in the general anesthesia was basically skull base, pan-sinus, malignant tumors, some orbital surgery, benign tumors, and we're all under general anesthesia. While you've got DCRs, inferior turbinate surgery, sinuses miscellaneous, like a maxillary sinus surgery, like a mesotoma or aspergillus surgery in the maxillary sinus, minimal invasive sinus therapy, or anterior atherectomy, if you want to call it, or all those were basically done under local. So it's an evolutionary process. It's not something that you can start, you can decide today and start tomorrow. You have to start slowly, take off like a plane, not like a rocket, because you fall down like a rocket, just the same. It can happen to the same thing as it's happened to the China unfortunate airplane when they were nose diving completely, and this can happen also to you if you do not start gradually. So first you start with something easy like a turbinate surgery and polyp removal in a formed cavity after the sinus surgery, and then you grow with your indications with the DCR, maxillary sinus procedures, chronic rhinosinusitis without nasal polyps, and then as a cherry on the cake, it's like a chronic rhinosinusitis with nasal polyps. So local anesthesia and endoscopic surgery is a concept. It's not something that, it's not just anesthesia itself. It's not a question of the room, different countries, different setup. It's not a question of the procedure because it should remain the same as you would do under general anesthesia. So the concept and why is that you have to perform the same surgery under local anesthesia, and you have to move the patients from the procedure to the procedure room, somewhere where you're not going to be interfered, or you're not be interfering to the others for a general anesthesia or the OR itself. And you've got a reduced set of instrumentation. And I want to add here that the power instrumentation is essential. So the whys is faster recovery, faster rotation, so you can rotate the patients faster. You can do more patients in local anesthesia as you compared to the general, and you avoid the general anesthesia side effects. So the problems at hand that we're going to discuss today are the indications, surgical techniques and instrumentation, anesthesia technique itself, because this is a really paramount competency, setting the procedure room, and I'm not going to touch the reimbursement because this is different in every country, and you have to let's say, manage it yourself, depending on the country you're working with. So the essential competence is that if you want to do procedures under local anesthesia, is that you have to be proficient in local anesthesia. You have to be proficient in the use of power instrumentation, because if you do not use power instrumentation, you get problem because the procedure is going to take longer. And you have to be, of course, proficient in endoscopic sinus surgery. And if you remember how we started to becoming proficient in the major endoscopic sinus surgery in general anesthesia, and then moved into the local anesthesia. So it's not something that you start as a novice. You have to be really proficient, and you have to be really competent in endoscopic sinus surgery, then you move into local. So patient factors are important. The patients need to be compliant, so no claustrophobia, no F diagnosis, as we call it, because you have to talk with the patient. The patient needs to be some sort of prepared that they're going to be 45 minutes under drapes with the nose sticking out. They might have a feeling, of anesthetized pharynx, which creates some sort of feeling of the foreign body. And how we select them is some sort of process of experience. So what I do is that if patient tolerates routine endoscopy without topical anesthesia in the outpatient clinic, then that's number one. Let's say for yes to the local anesthesia, he had experience with the local anesthesia, let's say wisdom tooth removal, something like that. That is also a good sign. And he didn't run away from the dentist. And he had no prior bad experience with surgical procedures under local anesthesia. So someone who was having a local anesthesia, I don't know, decades ago, and he was screaming and yelling because of the pain and because it was not done properly, then those patients are not good candidates for a local anesthesia. So established patient-surgeon mutual trust should be in every case. So if you don't have that, if you do not build up the trust between the patient and the surgeon, then you will also not be successful probably. So indications are primary surgery. What we started with was selective chronic rhinosinusitis with nasal polyps and the DCR, and then we moved on with a list of indications. And in the revision surgery, what we believe it's really nice indication is also the recurrence, or in the recalcitrant chronic rhinosinusitis, which means that the polyps regrow. You have to remove the polyps only because you're not moving the bone, because the bone was already removed during the sinus surgery, and you just shave off the polyps. Simple, easy, 15-minute procedure, and the patient tolerated it really well. So the lecture directory we're going to see today is that we're going to go through the procedure room prerequisites, essential competencies, essential instrumentation, some bits and perfect procedure examples in the surgical techniques. So in the room setup, what we think and what we are sharing, or what we believe, is that it must be quiet, it must be dark, it must have a limited number of staff coming in. So if you have problems with the procedure room should not be like it's a walkthrough. So everybody are going in and searching something in the closets, because it's going to distract the patient. It's going to limit your way. It's going to create many problems that you do not really wish to. And one of the most important things that we have seen is also that the patients who are being under surgery and finished with surgery should never return into the same room as the patients are waiting for the surgery, because they are going to create some sort of a lot of heroic stories on how it was like in the surgery, because patients like to do that, and they're going to make the patients in waiting nervous, and this is not a very good thing to start the procedures under local anesthesia. So where do you set up the office-based or local anesthesia procedure? Depends on your arrangement, regulations, local arrangement. But the room needs to have a basic patient monitoring, gases and like oxygen, good access to the emergency crew. So if something happens, and it may happen under local anesthesia, under procedures on local anesthesia, so the emergency crew and everything they need for the emergency crew needs to be accessible, and you have to have enough space to bring in the equipment. So this is how it looks like our procedure room. So it's a cart. You see the power instrumentation, simplified dressing, and this is what we did just a week ago. It was a VCR. You can bring in the image guidance if you want. You need to have a patient monitoring. But the procedure room, it could be nicer. It could be more provisionary, whatever works for you. Just that you have all those basic requirements in place. So it may be called procedure room, operating room for local anesthesia suite, whatever. There's no universal solution, depends on your working environment, hospital and clinics. And what is important is that recovery room needs to be separate, and we usually keep patients at least 2 to 4 hours, depends on where they live, so how far from the hospital they live, because you don't want to have some sort of complications like bleeding when they're on their way home. Now we come to the most important part, and these are the essential competencies that you need to have if you want to do the surgery under local anesthesia. So those are the surgeon competencies. Is the proficiency of a surgeon in endoscopic surgery. So there's no place for teaching at a local. You have to be proficient in local anesthesia, and you have to be versatile in the power instrumentation. We should not forget for the OR nurse or somebody that's going to assist you. She should be well versed in endoscopic surgery, so there's no time and place, to discuss, given this instrument, or what is this instrument, doctor? It's going to make the patient really nervous because they will think that the people dealing with him are totally incompetent. You have to radiate calmness, and you have to radiate, and you have to be speaking calmly. So the first and the most important competency is the local anesthesia. How do you do it? So it's a 2-step procedure in our place. Topical epimucosal anesthesia. So no spray, because it's going to they're going to start coughing. So you want to avoid anything that's going to influence on the patient and give him some sort of discomfort. And then its second step is infiltrative anesthesia, and the points that usually do. So middle turbinate, axilla of the middle turbinate, anterior and medial wall of the nose. So infiltration, topical anesthesia, you deal with a lidocaine mixed with adrenaline 1:1 ratio. And then this ensures a good vasoconstriction, number 1. And number 2, it anesthetizes topically also the mucosa. And then you infiltrate with the lidocaine and adrenaline in a ratio 1 to 200,000. You infiltrate septum, inferior turbinate, anterior axilla and sagittal portion of the middle turbinate in the pre-uncinate region. And posteriorly, you infiltrate in the sphenopalatine foramen. How do you do that if you have a nose full of polyps, or if you have problems with, or if you're dealing with a chronic rhinosinusitis with polyps? So this, how it looks like the infiltration for, let's say, some limited procedure in the interior compartment. I would say that, let's say DCR or minimal invasive sinus therapy. So that means uncinate resection, middle enterostomy, and the frontal sinus axis. So this is where you infiltrate, middle turbinate, axilla of the middle turbinate, and a lateral wall above the middle turbinate. Patients usually, if you do, so you see the patient is breathing calmly, and this is how infiltration is done. Now, if you got more comprehensive procedure waiting, so then what you do is that you, like in polyps, you infiltrate the anterior segment the same way as you would do in the previous video. So always septum, always inferior turbinate, which you also lateralize a little bit because then it gives you more access. And then you go to the axilla and the lateral wall of the frontal side of the nose, and and you're done. And this is good enough for removal of the polyps with a microdebrider, because those polyps are not innervated. So you can remove them. And then this is going to give you an access, like you see in a lower video, you're going to give you an access to the posterior tail of the middle turbine and the sphenopalatine foramen, and then you infiltrate in the second phase, also that region, which is going to constrict the vasculature of the sphenopalatine artery as well as the nerves, and you can proceed with them with the procedure from there on. The second competency is the microdebrider. So if you don't use the microdebrider, it's going to be hard for you to do the surgery. So this is like a very elegant procedure. So this is a procedure under local anesthesia. You can see we start with debriding the tissue because it's a really nice 4-in-1 tool. It cuts in the brides. You can pulp it and dilate with it. You can curette and remove, and you have always the suction in it. And this is really important issue. So we're not removing any bone right here. So this is a revision case, as you might see. The bulla was already open. First, you remove the polyps, and then you start to deal and palpate around where's the bone and where's the soft tissue. So you can remove the soft tissue without endangering anything. Once you start to remove the bone, then you have to be careful and you have to know and you orient yourself. But it's much easier when you remove the polyps. You can see that this is the first fovea that you start to cut, and you start to work your way up to the skull base and into the frontal sinus. So logical sequence, as we said, is to remove the polyps first. You can use the neuropathies to help you with this, let's say, pushing the tissue back, pushing the tissue in the right direction. You have to present the anatomy, and then you use the microdebrider to present the anatomy itself. So you see, now this is a virgin case, so a lot of polyps. You have to remove the polyps. There's a little bit of bleeding. Depends on how the patients are prepared before the surgery, and this is really paramount as well. And then once you stop and remove the polyps that are hanging loose in the middle, in the common nasal wall, then you can see that it's really nice. You can present the anatomy. So, and from here on, the procedure goes on as usual. Drilling is not usually suitable for local anesthesia. Exception is the DCR. You have to be proficient, and this is number 3 competencies. They have to be proficient in endoscopic sinus surgery, because under local there's different problems versus to the endoscopic sinus surgery as the general anesthesia does. You got to fogging up the endoscope, you got time limitation, you have to secure minimal bleeding, and you have to get the concept. And this is also the most very important thing of the surgical procedure itself. There are solutions for each and every problem. Fogging up the endoscope, you can advise the patient to breathe through the nose in and exhale through the mouth. This usually helps the fogging a lot. You have to be finished in 45 minutes. You have to use adrenaline topical and infiltrative, and you have to have a surgical concept of how you're going to do, because this is not something that you're going to do here, a little bit here and a little bit there. You have to have a real clear concept on what are you going to do during the procedure. There's no changing of the mind. So this is what we call compartmental surgery. It's an exact plan, and a sequence of the events that you're going to execute, because surgery execution is different. This should be in the general anesthesia. So this is what we developed, some sort of within our department, is that we try to do the compartments in full. So you all know the lamella concept. So this is something similar, just that it's the compartment in between the lamellas. Deviation from the usual procedure that you do under general anesthesia is the sequence of the events. So the sequential dissection of the whole compartment should be done fully before proceeding to the next one. In the classical teaching is that usually you're advised to leave the frontal recess to the end of the procedure. You have to do the anterior appendectomy, posterior appendectomy, whatever, and then you return back to the frontal recess at the end. Now, what we are advising here is that we do not like to do the bulla opening first, but we like to do the bulla intact technique. So you do the first compartment to the end, onset, middle enterostomy, and then you go to the frontal sinus and the frontal recess, and then you move to the bulla and the second compartment, we call it. So some compartments or the cells between the second and the third lamella after you have completed the frontal sinusotomy. So this is because you have limited time of surgery. You do what you must. So it's not something that you're going to do a little bit more because you know how to do it. In the local anesthesia, you do what you must. So what is good for the patient? There's no show off. So the compartment surgery, the first lamella. So the first compartment is really the compartment that is between the first and the second lamella and includes everything from the onset to the agar nasal cells, and those are very important, and we're going to show you a little bit of that. So you all know the anatomical relations between the frontal sinus and the agar nasal cells and the onset process. We're not going to repeat it, just that you remember it. And it's the vertical bar concept that Aldous-Tam really developed is the basis for this kind of surgery that we do, because we identify the inlet into the frontal recess and follow the natural drainage pathways into the frontal sinus to the vertical bar concept with bulla intact technique. So that's there are two ways of draining of the frontal recess. One is medial and one is more posterior. So this is like you see we're doing with you do with the microdebrider. You resect the agar nasal cells and the front agar cell, and then you do an osteoseeker, which is our really basic instrument. You find your natural drainage pathway medial to the agar nasal cell wall. You collapse the agar nasal laterally, and you debride and remove the tissue within. This should give you an access to the frontal sinus, and you can see the bulla is still intact. The second way of getting into the frontal sinus depends on the fusion of the onset and the agar, is that it's going to be posterior medial. So this here is going to be the way to the frontal sinus. So again, you use a seeker to get into the frontal sinus, following the natural drainage pathway, collapse the agar nasal cells, remove it with the microdebrider, and here you go again with intact anterior wall of the bulla. So that's the concept. It really suits the local anesthesia. You can do it in the general as well. We do it, but this is the paramount thing if you want to do a local anesthesia correctly. Otherwise, you're going to start to do the mishmash of the mucosa hanging all over the place. This is not going to be clean surgery. It's going to take more time than you really have. So we come to the essential instrumentation. What we have is we have a really limited cold instruments tray. Free or ostium seeker, wild Blakesley up and down, pediatric through cuts, circle punches, Carrison optional, and suction straight and curved. But we do it microdebrider at 12 or 40 degrees up. So that's the tray. So I see I'm not really screwing you up. So this is a tray for endoscopic procedure for inflammatory disease if we go for or for benign tumor. If we go to the skull base surgery, it's a different concept, different instrumentation. Then what we really like is those curved instruments, microdebriders that are 360 degrees rotatable, because you can do with the rotation with a very small movements, of your finger, you can rotate the tip of the instruments. And this is how you do it. First, again, see the concept. First, you remove everything that is hanging loose, like the tissue. That's number one. And then you start to follow. You have to start to remove with the microdebrider. You remove the onset process. So you're doing minimal invasive sinus therapy all the way. You remove the sinus. You remove the polyps hanging in the axilla. You see how the tip is rotating, and the arrows are pointing to the opening where the microdebrider is working. And you know that depends on where you are. You have to be careful on which part you're pointing the opening to. And then this is again our very essential instrument. It's an ostium seeker. You go and follow the natural drainage pathway. Once you establish the natural drainage pathway, it's really not something that you can really do. And then you just proceed on with the microdebrider, debride what you have crushed and dilated. So this is something that we have really. The only thing really, and sorry to say that, but the only thing that really we have adopted from the sinus dilation procedure. So you dilate it with the ostium seeker, and then you use your microdebrider to remove. Sometimes you use the punches, called still punches, because they're reliable, safe, but you come to the same stuff. Image guidance, it's possible to incorporate. We have done it. It has to be usually magnetic, because optical with with all that crown that you have to mount on the patient, it's really uncomfortable and probably not really adaptable under local anesthesia. So it has to be adhesive too, and it might help you decreasing surgical time, which is also good. So which are the surgical cases suitable for local anesthesia? We're not going to talk about turbinate surgery. We're not going to talk about selected sphenic sinus pathology, because this is a little bit too, one is very simple and the other is a little bit too advanced. So we're going to stick to the core business. So it's a polypectomy of the pansinus. That's a reboot surgery, as it's called today. DCR, myelontrastomy, and I'm going to show you tips and pearls for every and single step. So this is, so you see the video is 17 minutes long. So this is a patient after the pan-sinus procedure with a polyps between the operating cavity. You see that the shaver and the microdebrider is used for debriding the polyps within the operating cavity, and this is from start to beginning, and this is how it looks like after the surgery. So remnants and the bone you leave alone. All you remove is just the soft tissue that's hanging loose, because you're doing something to alleviate the patient. You're not treating the disease itself. The DCR is my, let's say, really, I really like this procedure on the local. It can be done primarily as a revision, but there are special considerations on the DCR for the local anesthesia, because you have to do it in addition to the anesthetizing that anterior compartment. You have to infiltrate as well the region outside of the lacrimal fossa, so that transcutaneously. And those are 3 points that usually what we use. You have to be careful here not to infiltrate in the angular vein. So intratumoral anesthesia with all the precautions that are needed. And you have to go with the needle down to the bone, because the bone and periosteum on the outside are being innervated, and therefore you have to infiltrate the periosteum as well. Otherwise, the patient are going to feel pain once you get through the bone on the other side to the lacrimal sac. How you do that after the infiltration? We all know the procedure is very simple. So this is just the DCR. What we like to do is that what we have seen is that the burring, so the drilling of the bone with after the DCR with the DCR is much less painful for patients than compared to, let's say, the Kerrison, because you have to use a lot of angulation. You have to put strain on the septum and on the other parts of the patient, and this is something that really is discomfortable for the patient. So this is like a revision surgery. You see that there's a lot of scarring. You have to enter into the sac and make micro flaps, and in the end, we usually, in the revision surgery, we usually put the Jacobson tubes, but otherwise we do not. The same concept is also the fungal ball. So this is a very old video, as you can see, somewhere at least 10 years old. And you can see that the fungal ball can be removed under local anesthesia. So this is aspergillus masses that are coming from the maxillary sinus, and you do the same thing as you would do in a normal procedure, uncinate removal. But under local, you have to infiltrate. If you do a middle enterostomy and start to poke around in the maxillary sinus, you have to infiltrate the sphenopalatine foramen as well, because it's at least posterior part of the maxillary sinus is being innervated from the sphenopalatine foramen, and once the patients start to feel pain during the surgery, you're done. It's not going to return to normal, no matter how much local anesthetic you've done. So this is really, really important that you do your local anesthesia and then wait so that it starts to work. Not that you just infiltrate and start to drill, because it's not going to work. So you have to give at least 15 or 5 to 10 minutes to start working. You chat with the patient, you talk about his family, so you both feel relaxed, and then you start your surgery. And as you can see that afterwards, this procedure is really it's done the same way as it would be done under general anesthesia. Chronic rhinosinusitis without nasal polyps, it's paramount to dissect the first compartment as a whole. So this is where we started. How we use it. So this is again the vertical bar, frontal sinus, and the curved shaver and the curved microdebrider. And you see that you can do and dissection and dilation under good circumstances or good local conditions. You don't need not even the sicker, but you can dilate the frontal recess with the microdebrider itself. When you hit the harder bone, sometimes it's necessary to use cold steel instruments as well. Polyps, we have said, and we have already talked about that, how to do it, especially when it comes to the local anesthesia. When it comes to the local anesthesia, you have to do a sequential anesthesia, debridement, and anesthesia of the sphenopalatine foramen. And again, the debridement of the polyps is much faster with a microdebrider than it would be done with the cold steel instruments. And this is really what we are some sort of advising. And now you see that once the polyps are removed, you start to infiltrate into the posterior part of the of the nose and into the tail of the middle turbinate and into the sphenopalatine foramen. And sometimes you add a little bit here anterior wall of the sinus, and then you proceed into the frontal recesses here again with the microdebrider, removing the agar nasal remnants, and the bulla is still intact. So if you do that, this kind of procedure, and this is what we're doing because it's safe and because it's fast and because it's usually this is what is necessary, is that you have to do resection of the frontal recess as a whole. Cold instruments might be necessary, as we said, because sometimes it's just too hard and too dense bone to get along with a microdebrider. So the entry into the frontal sinus is going to be here. This is the anterior wall of the bulla, and then you use the curette, you use the sphenic punch, frontal punches, and you are up here in the frontal sinus. So that's a typical case that we do under local anesthesia. Why I'm showing it, because it was done under local anesthesia. So this is really, you can see the infiltration. This has been done on our first course in 2019, before the COVID started, and it was live surgery under local anesthesia. The patient is, it has started to cough at the beginning, a little bit of blood. This is not something that you should be afraid of, and they should be advised with that, because usually when they calm down, everybody are a bit nervous because they were on TV on showing, and it's still accessible. The whole lectures are accessible on YouTube on that link. It's something that you do, and you see that the whole procedure was done in 24 minutes. So that's the surgery that you do. Microdebriders. So this is some true cuts. You have to, because you have to. In the end, sometimes you still need cold instruments for touch-up finishes, and you can see that that's how things look like. So this is how things look like in the end, and the happy patient and the happy surgeon, the colleague of mine working with it. So with us in the department, and this is what we do, because this is the basic competency of all rhinologists working in our department, is that they are able to perform this procedures under local anesthesia. So the tips and pearls from my side on how to move your site into the local anesthesia is that you start slow with simple cases. You start to fight with the defogging of the endoscope. So breathing, advising the patient to breathe in through the nose and exhale through the mouth is really helpful. Together with all the defogging solutions that we all use, but still sometimes when you start to breathe, it does not work well, or it's not sufficient. You have to be able to decrease the operating time, so you have to be proficient in surgery. You have to use the powered instrumentation if you feel more safer. Also the image guidance, no doubt about it. It can be helpful, especially in the beginning. And I must not stress enough the really importance of the quiet working environment. It's not something that people are screaming and yelling and all kind of noises, because patients are under local anesthesia. They're listening around, and it's not really some sort of factory that they're in. They need to have the calmness and a competence and a competency irradiating from the environment and the surgeon itself. So that was let's say what I had to say about our experience and our concept of doing procedures under local anesthesia, and I will happy to take any questions that there might arise.
Thank you so much, Boštjan. It was absolutely fantastic, and thank you so much for sharing your actually really long-lasting experience. I have a couple of questions for you in a way related to the almost 2 decades, yes, or more than 1 decade that you have been practicing.
Yeah, 15 years, something like that. Yeah.
Yes. So let's start with something you touched at the end of your presentation, and we can address it for your beginning more than 10 years ago and your fellows that you train on a daily basis. What's the difference for you, or what kind of tips or expectations you set up for your trainee when they prepare for the local anesthetics procedures? So let's say you have the same kind of sinus target surgery and then the same in local and general anesthesia. How you how you prepare your younger colleagues, what they have to do differently, remembering what you stressed so many times so wisely, and what Rodney Schlosser has been teaching us for the over 2 decades, that the endoscopic sinus surgery is a structured journey. Yes. So what's the difference between the preparation for the local and general anesthesia sinus procedure?
So first, all the trainees or the residents, they start to do under local anesthesia a lot of procedures. So I didn't even mention the septoplasties, which is the basic procedure they need to know how to do. So they can use an endoscope. Sometimes it just is, there's a spur to be removed, and this is all done under local. And this is the basic, let's say, the competency of the surgical procedure they need to master before they're moving into something more. And they always start with under general anesthesia. So they start with cases in general anesthesia to get proficient to get proficient in endoscopic sinus surgery, to that extent that they are able to do at least certain parts of the surgery itself. Usually what we do is that the residents are doing very limited, during the training period, are doing a limited surgery. So that means that they do some parts of the surgery, but they do not complete the whole thing. Because as I said, it's not a teaching process for local anesthesia, because you cannot, it's distracting for the patient. So you have to be, local anesthesia is something that you do once you are proficient. And then once they do, and once they're proficient, they do the same thing all over and again. The preparation is the same. They radiate something that they know what they're doing. And this is really good, important thing. So the patient needs to feel that you know what you're doing and that you're proficient, and then it's half of the job done. And then everything goes on the same way as I described it. So it's not something that we just throw in the residents. This is something that fellows or post fellows are doing. It's not a surgery for residents. I must say that it is not what we're doing. Yes, septoplasty, yes, but anything beyond the septoplasty becomes more. It's reserved, let's say, for the rhinologists, because you want to have a proficient man working with it, and then teaching is for general anesthesia. And what I must stress that we are using image guidance in general anesthesia, even if you don't really need it. We just set it up, especially for the residents and for the people in training, because we feel that the image guidance and the best added value for the image guidance is basically the teaching tool. That's where I think it just brings another perspective in understanding of the anatomy. And once they do that, they can move in.
Okay, great. Question from our audience, and it's bound to the comment I wanted to make. Have there been cases where you had to convert to general anesthesia? And maybe, Boštjan, it's good to stress that your local anesthetics are performed in the operating theater, yes? Is it correct?
Yes. Mm-hmm. Well, we say basically yes. So this is why I said the procedure room, the outpatient room depends on your local arrangement. This is it's under the clinical department, but it's a special, we would say, non-functional operating room for general anesthesia. But it was general anesthesia room, or it was like an operating theater. Now it's for a local anesthesia. So you do a tonsillectomies under local, you do everything under local, but it has a really nice access to anything that can happen for the general anesthesia. If you have to convert it, which happened, I would say in a handful cases in the last 15 years. I don't know the exact number, but it's really, I think I can remember 2 of mine, maybe 2 or 3 from the others. I would say 5, max 10 out of those 500 and something cases that really had to go for, you have to stop and go for the general anesthesia next day or something. But this was usually because of the patient discomfort or because the patient was judged incorrectly. We're trying to move now certain parts or certain procedures into the other room, which is even further away. But as I said, the problem is that it depends on your local arrangement. What we don't like in this, let's say, new arrangement that we're trying to figure out because we want to move, because we want to expand, is that the patients will have to go through the waiting room area. It was not going to be quiet because there's too much of the people going around. So whatever you do, you have to really have these are requirements that you cannot just bypass. And if it's the OR, because what in the Slovenia also I want to stress is that we have enough of ORs, but you don't have enough of the anesthesiologists. So it's easy to just scavenge some of the one of the older ORs for local anesthesia than to bring in the anesthesiologist in. So this is really nationally or top or local dependent on how you're going to arrange it. Okay. So this is Yusuf is typing the answer already.
Yes. So I would like to continue this discussion. So can you tell the audience how you schedule your list per week? Do you do every day some of the local anesthetics, or you have the day devoted purely to local anesthetic cases?
So so it's a team, as I said, working. It's not that just me, because if it's not a single man. So yes, you are there for alone, but what we wanted to increase this, not in the most kind way, the production, which means that the number of surgeries, and then you have to, because different people have different responsibilities on a different day. So there are 4 rhinologists now working, and we have 4 days of local anesthesia services per week, and 2 to 3 days for general anesthesia. Depends on, but we're competing for general anesthesia with our subspecialties of the head and neck, which means head and neck of DNT, head and neck, otology, so on and so on. There are certain days are fixed, but the local anesthesia is basically more or less only the rhinology is done on the local anesthesia. Some parts of some segments of otology as well, like staphylotomies and so on. But mainly what we do is 4 days of surgery and local anesthesia. And those are everything, mixture of everything, because you want to be finished, let's say we're in a country where the working hours are very important, especially for the staff. So it means that you start at 8:30 and you have to finish until 3. So that's it. And we can, on a good day, that means that 4 endoscopic procedures during that period of time, because the rotation is really faster. You can do 4 endoscopic procedures per day under local anesthesia. But again, this is really, I have seen done more and I have seen done less. Depends on the local peculiarities of, let's say, depends on which country you're working at. But this is what we have seen that it works for us. And this is really the most important thing. Do not copy something from states or from us into your environment, because it just might not work. But what you copy is the concept, and then you arrange it within your limitations. And you have to understand also that there are cultural differences between the nations, and everything that must be taken into the account. And this is why that what you copy and what you take over is the concept, not copying the whole arrangement. This is going to vary from the country to the country.
I think it's a very, very, very important comment. And the last question related to the staff and the OR setup. When you back off to over 10 years ago and today, do you remember how you prepared your OR staff, your scrub nurses, your team for local anesthetics when you started? And also, what did you change over the years? What kind of eventually lessons you took that modified your approach? Or maybe there is something that you learned through the local anesthetic experience that you decided to apply for your general anesthesia cases.
So that's everything is an interplay. So what we started is 15 years ago, let's say 2008, we really started to do, the endoscopic surgery has been done in our country after the Stamberger. So 1 year or 2 years after the Graz, because we were already in close proximity. But this has been done. It has been done, let's say, I would say in an old-fashioned way with cold steel, and then the introduction of the shaver and the microdebrider was pretty late in the Europe, as you know. But we started, and I think the new era really started with the introduction of the microdebrider on department. That was in 2008 and 2009. Then everything took off. What we started is that we started with, so the journey was like 20 or 25 years ago, there were 3 instruments, Wild Blakesley, Freer, and a suction, end of story. So you have to do it with everything with that. And then when we moved into the new department, we multiplied the number of instruments enormously. So it was like 50 instruments there on the tray, the Stamberger set from Storz, everything was there. And then we started to do that. We started to introduce the microdebrider. And what we figured out is that we're using 5 or 6 instruments, nothing more, and a microdebrider, of course. And all the rest was just junk there, not being, let's say, taken into the hand of the surgeon, not many times. The real thing that were the Blakesleys, the Trucats, the Carrison, the ostium seekers, or the ball probes, if you want to call it, and the Freers. All the rest was really used, I would say, scarcely in the last years. So we dumped it. So this is what we ended up a few years ago, that we ended up with just a limited number of instruments. And this is what we use for FES now, nothing more. And if you go to move to the skull-base surgery, then okay, then everything starts to multiply, because you need a little bit smaller instruments, bigger instruments, curved scissors here, scissors there, and so on and so on. But it's different concept, different surgery. But this is what we started this was also easier for the OR nurses. The OR nurses, and this is what I must say, OR nurses are dedicated ENT OR nurses. So it's not something that they rotate all over the place and they do abdominal surgery in the morning and ENT in the afternoon. So it's really dedicated nurses, and they know how to handle the instruments, and they know the names of the instruments, obviously. And it was also a great deal for them, picking up all the instruments and looking at them, never being picked up in the hand. So we dumped it, and we ended up with that limited tray, which works perfectly. So it's like life. We started with on one side of the pendulum, we went into the other side of the pendulum, and then somehow we converged in the middle. So the next generation has something to offer to the surgery and to the patients as well. Probably, I don't know what's going to happen, but it's really a generational issue, I would say. So the generation before me, it started slow. We made it, maximize it, and then we went into the middle, and now the next, and it's also it was also like a real let's say input from the next generation, and now the next generation is going to add up another thing. But the concept lives, and that's the most important thing. It doesn't really it's not the names that are important, it's the concept, and this is what we are trying to build up here. It's not like that we are trying to build the monuments for every person and for the name, but the concept is there, and what we are trying to nourishing is the concept of the local anesthesia, because we believe it's really cost effective and good for the patient. That's it.
And the little additional question to that. So when you prepare for the case, let's say this is a sinus, and the scrub nurse can only see, okay, today we do whatever the do you have a little bit detailed discussion with your scrub nurse before you begin the procedure? So to have every instrument that you need in place, is it necessary, or your circulating staff is quick enough to bring what you need?
They know.
Okay.
Yeah, they know what. So let's say they when it's a DCR, they always know that it's a burr, and they know that there's micro scissors that they need to open as an addition. If it's an FES case, they know 40 degrees for my colleague who's always working 40 degrees. They ask me 12 or 40 degrees. I say, okay. So usually they ask you, because they know the surgeon, and they know what we are spending more time than with the family. So they know your requirements and your little, how you call the instrument. And usually that's just it's a 5-minute talk for the whole list in the morning. So this is going to be done, and they discuss it with the operating surgeon. So because everybody have their own peculiarities, me, the other people, everybody. So because we have also different shavers. Some people like this one, some people like that one. Depends on the situation, depends on the surgeon, and also the case. Sometimes it's just case dependent.
And the very last question is, we are over the time. It's a technical surgical question. You demonstrated the fungal ball case in the maxillary sinus. Normally in the general anesthesia, we do use a lot of washing of the media. So how do you manage the cleaning the sinus in the local anesthesia?
Well, it's messy, but the patients like it a lot. So you have to just prepare them. So first you do the opening, you remove as much as you can, and then you say, oh, now we're going to wash. So don't worry, just don't swallow it if you want it. It's not going to happen anything, but it's going to be only the saline. It's going to be just salty water. So if it comes into your mouth, spit it out. So we're covering his mouth and he spits out a lot of, or we introduce we are experimenting with a lot of things by introducing a suction on a suction catheter from one nose and just leaving the suction there and irrigating at the same time, so that that suction irrigation comes in, or the nurse helps you so that you minimize. So they are holding the suction in place, and you just irrigate, and they usually suck more or less everything. If there's something that comes into their mouth, they spit it out or they swallow it. So you have to negotiate that with the patient. And at first they're a little bit scared, but after 1 or 2 trials, they really like it. They really like it a lot. But it's something. This is why it's still the surgery, and it cannot be done with a shirt and tie. So the patients who are coming in, they need to be prepared and in a certain in a clothes for surgery. It's not something that you just walk in, just undo your tie and then the shirt and start to do the surgery. It's not. It doesn't work that way. So it can be a little. It can be a little messy, like it would be in the general anesthesia. So it's the same setup, I would say, as for general anesthesia when it comes to the cleaning the patient, but much more simplified, and they really help you. So we didn't have any problems that somebody is going to choke or something like that. And we did a lot of fungal balls in the in that local, but it's a journey.
Professor Boštjan Lanišnik, thank you so much. I think it was really phenomenal, and thanks a lot for so many tips and tricks you shared with us. So thank you, our audience. Thank you for deciding to spend some time with you, and we are looking forward to meet you in the future. Thank you so much.